Okay, this class is fecal diversions in children. We're going to focus on indications for fecal diversions, the type of diversion that might be done, and then the basics of management with a particular focus on pouching modifications for the pediatric patient. So let's start just with some general concepts. First of all, most fecal diversions in children are either due to a congenital condition that causes obstruction in the GI tract, and the diversion is essential in order to be able to feed the baby, or it's due to an acute inflammatory process. And we're going to discuss the specific obstructive lesions and the specific inflammatory lesions. Also, as you see, most commonly fecal diversions in children are temporary. It's uncommon, very uncommon today to have a child with a permanent diversion. It might happen, but it's not common. Thirdly, when you're taking care of an infant or a child, of course you have to be equally concerned with the parents. They're the caregivers initially. If it's a newborn especially, or if it's a child with a newly diagnosed acute inflammatory condition, those parents are in a state of shock and they need a lot of support as well as education. And then finally, when we're providing pouching for our pediatric patients, we have to remember that pediatric skin is not the same as adult skin. And this is particularly true of neonates. We talked about this in the wound module, that at the time of birth, the stratum corneum, the outer layer of the epidermis, is very, very immature because the baby's been floating in a sterile, moist environment. Once the baby's born and the stratum corneum is exposed to the air, it begins to mature. But even in a term newborn, that takes at least 2 to 4 weeks. And a premature is going to take much longer. That means that when we're selecting products for use on a pediatric patient, we have to make sure that those products have been tested for safety in the pediatric population, that abnormal permeability of the skin that persists for 2 to 4 weeks after birth means that we have to avoid anything that's alcohol-based, because that alcohol would be absorbed through the skin into the bloodstream. So we avoid products that are alcohol-based, or if the alcohol is used as a solvent, for example with paste, you can apply paste to the back of the pouch, put the pouch to the side, allow all of the alcohol to evaporate, and then apply the pouch to the infant. So you're always very cognizant of anything that could be absorbed. We also have to be very cognizant of the risk for skin stripping. So we have to be very careful with pouch removal. We also have to be very selective with our products to select things that do not have such aggressive adhesion. So we're going to come back at the end of the class and talk about those principles of pouching again. But they're so important, I thought we'd mention them at the outset and then again at the end. Okay, so now let's focus on problems that might require diversion. Now as we go through, I'm going to cover some conditions that are less common, that are less likely to result in diversion. And I'll tell you, don't focus on this. I will talk about other conditions that are more common and are very likely to result in diversion, and I'll tell you, study this. So the first two conditions, gastroschisis and omphalocele, are uncommon and very unlikely to result in diversion. I am going to go over what these terms mean, what these conditions involve, but I'll tell you right now, this is not something you need to focus on. This is more for reference than for study. So here you see gastroschisis. And of course, you can imagine how traumatic this would be for parents to see their baby with the bowel on the abdominal wall. And that's what gastroschisis involves. A significant section of the bowel is located outside the abdominal surface and sitting on the abdominal surface. In addition, the section of bowel that has herniated to the abdominal wall is frequently shortened and thickened, And that means that they can't just do a quick surgical procedure. If it was a small section of bowel with no significant changes, then they would be able to do abdominal surgery, open the abdomen, put the bowel back in, close the abdomen. But as you can see, there's a significant portion of the bowel. The bowel is thickened, the bowel is edematous, and they can't just put it back in. So they have to go through a staged management approach, and I'm going to come back to that in just a minute. Now I want you to notice that most babies with gastroschisis have a good outcome. The mortality rate is low. Most of these babies do not have any other significant anomalies. So even though it's overwhelming for the parents, if you are ever involved in providing counseling and education for these parents, you can be very encouraging that this is fixable and that long term this baby's expected to have good outcomes and normal bowel function. So it's very, very distressing, but also very fixable. You can't say the same thing about omphalocele. So with omphalocele, the problem is that you have herniation of the bowel through the umbilical ring, and it's covered by an amniotic sac. Actually, the bowel itself is usually normal. It's much easier to repair omphalocele most of the time than it is to repair gastroschisis. The problem is that with babies with omphalocele, most of them have other major anomalies, and so there's a very high mortality rate. So even though the bowel looks better with omphalocele than with gastroschisis, the overall outcome is much more negative. Now let's talk about management. Initially, they typically do this procedure called silo. I'm going to get out of the way so you can see this. So they wrap the bowel sometimes in sterile moist saline gauze and then put it in a sterile plastic bag. And sometimes in this case they didn't even wrap the bowel with gauze. They just put the bowel in the sterile plastic sack, secure it at the base, and then elevate the sac. And what they're doing is they're elevating the bowel just above the abdominal wall so that you get gradual reduction in the edema. Also, it gradually stretches the opening in the abdominal wall. So the combination of gradual reduction in edema and gradual enlargement of the opening in the abdominal wall makes it possible then to do surgical repair. Now, we've already said that diversion is uncommon, but you might be consulted because of problems with wound healing. Many times they will end up with an anastomosis under tension. Sometimes they get dehiscence. And so sometimes you are consulted for assistance with wound care and even for negative pressure wound therapy to promote healing. Okay, so I want you to know that this information is in your module. Should you ever be consulted for a baby with either of these conditions, I want you to be able to look it up and know that they're going to use silo to reduce the edema in the bowel wall. And I want you to know that management is surgical closure. But I don't want you to study it for the test. Oops. Okay, the next thing I want to talk about is volvulus. Now, if you have already studied the section on indications for colostomy in adults, we talked about volvulus in adults. Volvulus in children is essentially the same process, although different sections of the bowel may be involved. But once again, you have twisting of the bowel and the mesentery on itself. When you twist the bowel and you twist the mesentery, you get a very negative combination because you're going to get rapid distension of this section of bowel. It's a closed loop obstruction, meaning that it's closed here and it's closed here. The glands in the bowel wall are going to continue to secrete fluid. The bacteria will continue to produce gas. You're going to get very rapid distension. In addition, as you see, the mesentery is twisted, So you get rapid development of ischemia and early perforation. Volvulus is a surgical emergency. It's always a surgical emergency if it's a full volvulus. These babies present with acute onset of pain, rapid distension. They go straight to the operating room. They're going to resect the necrotic bowel. And almost always in children and in infants, they'll bring both ends of the bowel to the abdominal wall. So most of these children, most of these infants will end up with a proximal stoma that's functional and a distal stoma that produces only mucus. Some surgeons put the stomas right together, so you end up pouching them together. Other surgeons separate them so that you're pouching the proximal stoma and dressing the distal. All you really need to know about volvulus is what the underlying condition is. Once you understand the underlying condition, obviously you're going to know that surgery is essential, that they'll take out the necrotic bowel. The one thing that you need to know that's different about pediatric patients and adult patients is that in pediatric patients, typically they bring both ends of the bowel to the abdominal wall, so you typically have two stomas. Obviously, it's temporary, and once the intra-abdominal infection has resolved and the baby's stable, then they'll go back and reconnect. Now, the next thing we're going to talk about is atresia. Atresia means loss of continuity. So you've probably heard of tracheoesophageal atresia. We're going to talk about rectal atresia. But atresia can occur at any point along the length of the GI tract. And it's thought to be due to vascular access in utero, so that as the bowel is forming, one section fails to tubularize, and either you end up with two blind ends, or sometimes you end up with just a non-patent section of bowel in between two sections that are patent. So let me just show you a couple of things here. On top, you see esophageal atresia and the different ways it can present. So in this case, you have esophageal atresia, but no connection to the trachea. So what would happen with this baby is this baby would be unable to swallow because there is loss of continuity between the proximal and distal esophagus. That would be a complex repair. Typically, the baby would end up with a temporary esophagostomy where they would bring the proximal end of the esophagus out to the neck to drain saliva, and then the baby would be fed through gastrostomy. Long term, they usually use a section of colon to reestablish continuity between the proximal and distal esophagus. Here you have esophageal atresia where there's a fistula into the trachea. So you've heard of tracheoesophageal fistulas. Again, they would have to do early surgery. This baby would have respiratory distress as well as the inability to feed. So they do early surgery to separate the esophagus, bring it out onto the neck. Here, the proximal esophagus ends in a blind pouch. Distal esophagus is fistulized to the trachea. So you see just a variety of different forms. You don't need to study the different forms. You just need to recognize the terms. So if you read that, if you're consulted and you read on the chart that the infant has esophageal atresia, I want you to know what that means, that there's no continuity between proximal and distal esophagus. I want you to realize surgery will always be required, that temporarily they'll bring the proximal esophagus out to the neck. Pouching will be required. So anytime you see a patient with an esophagostomy, you know that there's going to be a lot of drainage, saliva, and anything that baby swallows. So if that baby is allowed to feed just for normal development, then whatever that baby drinks is going to come out through the esophagus. Okay, now ileal atresia, here you see normal bowel, and then you see this section where there's just a band that is not patent, ileal atresia, easily addressed, promptly diagnosed at birth because the baby cannot tolerate feeds. If there's an atresia anywhere in the GI tract that cannot tolerate feeds, X-ray clearly shows loss of continuity between this section of bowel and this section of bowel. If it's in the small bowel, whether it's duodenum, jejunum, ileum, they just go in, resect the little section that is non-patent, connect the two ends together. No ostomy is required, and you would not be consulted. So I want you to know the term, but I'm not going to test you on that because that's very unlikely to result in a diversion. At the other end of the bowel, however, if you have a baby with rectal atresia, what it means is the rectum ends in a blind pouch. There's no anal canal. Those babies obviously require colostomy, but we're going to talk about that under the broad category of imperforate anus in just a few minutes. So, what do I want you to know so far? I'm not going to test you on gastroschisis or on ballicele. In terms of volvulus, I do want you to know the basic pathology involved in volvulus, and I want you to realize that in the pediatric population, almost always they do both a proximal stoma and a distal mucus fistula. I will not test you on atresias. It's in your module because you may be consulted and because we would want you to know to expect an esophagostomy in a baby with esophageal atresia and to know that you would need to pouch that. But the next one we will definitely test you on. This is Hirschsprung's disease. Now, when we talked about indications for colostomy in adults, we talked briefly about congenital megacolon versus acquired megacolon. The official term for congenital megacolon is Hirschsprung's disease, named after the German physician who first identified the condition. So you know, I hope you remember a little bit about this discussion. I'm going to go through it with you again. Here you see a depiction of the normal nerves in the bowel wall. We know that muscles work only if nerves are there to tell them what to do. You remember from our discussion of A and P of the GI tract that the bowel has very rich supply of nerves. You have multiple nerve plexuses, multiple nerve cells throughout the bowel wall that controls peristalsis. We talked very briefly about the fact that innervation during fetal development, innervation of the GI tract occurs proximal to distal. So first the stomach, then the small bowel, then the colon, finally the rectum, and the internal sphincter. So if innervation occurs proximal to distal, and if there is any failure of innervation, it's always going to involve the most distal sections of the colon and the rectum and the anal sphincter. So here you see what is commonly referred to as short segment disease. You have nerves all the way to here. And then the last part of the sigmoid, the rectum, and the internal sphincter lack nerve endings. They do not have any nerve endings, and that section of the bowel is not capable of peristalsis. Another way to look at it, if you have a child with Hirschsprung's, what will always be involved? Well, what's the very last section? The internal anal sphincter. What does the internal anal sphincter do? Well, it normally provides continence at rest, but it also opens in response to rectal distension, and that allows stool to pass through the anal canal for elimination. But if the internal sphincter has no nerve endings, it never opens. It stays passively contracted all the time. So if you have a child with Hirschsprung's, does the internal sphincter ever work? No. The other section that's always involved is the rectum. Part or all of the rectum is always involved in Hirschsprung's. And many times part of the sigmoid. There's a small percentage of children who have additional sections of the colon involved. About 10% have variable lengths of the colon involved. 10% have total colon aganglionosis, but 80% have this short segment disease. So we're going to focus primarily on short segment disease. We'll talk briefly about long segment. So let's talk short segment. Here, we've already said the internal sphincter doesn't open, so you have more resistance to stool elimination. Add to that the fact that the rectum is always involved, at least part of the rectum is always involved. So that means the rectum does not contract to push stool through the anal canal. And sometimes part of the sigmoid is involved. So then you have this section of bowel at the very end where you have formed stool that's not working. The section that is denervated collapses on itself and becomes a very narrow pathway, and it's very hard to push the stool through that narrow pathway. Now, when you look at this slide, I know that this section looks like the damaged section, the disease section. That's actually the normal section. So here's the problem. This section is not working, is not pushing stool through. So it's like a section of conveyor belt that is stopped. And then proximal to that non-functional section, the bowel distends for two reasons. One is that stool backs up, and so you get progressive distension, dilatation of the proximal bowel. But also the muscles in the proximal bowel are working very hard to try to push stool through that non-functional section. So you actually get hypertrophy of the muscles in the bowel wall. So the combination of muscle hypertrophy and accumulating stool causes major distension in the proximal normal innervated bowel. So this is the normal bowel. This is the denervated, non-functional, obstructed bowel. Okay, how does this baby get diagnosed? Well, because of the fact that the proximal bowel does compensate for some period of time, diagnosis is frequently delayed. Constipation is not uncommon in infants. And so if a mom reports to the pediatrician, I think my baby's constipated, he or she strains a lot, they're not stooling as often as my other babies did, initially the pediatrician is probably going to say, constipation is common in infants, let's do this, let's do that, let's add this to the formula, whatever. But when that constipation persists and becomes more and more severe, when that baby begins to develop abdominal distension, then both the mom and dad and the pediatrician start to recognize this is not normal, run-of-the-mill infant constipation. That's when the baby is sent to a specialist, and that's when the diagnosis is made. How do they go about diagnosing Hirschsprung's? They can do just a plain x-ray that will show usually the collapsed section and then the dilated section. They talk about this as the transitional zone of narrowing, so that's a classic x-ray finding. If they do a very gentle rectal exam, what's going to happen is they'll find a very, very tight anal canal because the internal sphincter is always collapsed. And then, and this is a very classic finding, when they withdraw their finger, there will be explosive elimination of stool and gas. It's like follow the finger, follow the finger, follow the finger, because everything that's been trapped in that distal bowel is now trying to get out. But the one test that provides a definitive diagnosis is a rectal biopsy. You have to do a biopsy of the rectal wall, and you have to examine it under the microscope to see, are there any ganglion cells? Is this section of bowel denervated. If you have ganglion cells, then something else is going on. But if there are no ganglion cells, then that confirms the diagnosis of Hirschsprung's disease. And here, again, what you would see, flat x-ray, transitional zone of narrowing, very distended, dilated, descending colon. Rectal exam, probably explosive elimination of stool and gas. You do a rectal biopsy, and what's it going to show? No nerve leads. Okay, so now we have a diagnosis. So clinical presentation, severe persistent constipation, gradual abdominal distension. Diagnostic test, flat x-ray typically, sometimes a rectal exam. They're very careful about doing rectal exams in children, but sometimes they will do a gentle rectal exam. And the definitive test is rectal biopsy. That might be a test question. So you should know that the definitive diagnostic study for Hirschsprung's disease, rectal biopsy, to demonstrate absence of nerve cells. Okay, so now we know what the problem is. What are we going to do about it? Well, you cannot go in there and do a definitive repair because you have this distended, dilated bowel full of stool. What you're going to need to do is you're going to need to connect the functional innervated bowel to the anal canal. But you can't connect this very dilated colon to the anal canal because it's such a mismatch, okay? Big bowel, narrow anal canal. So the first thing they're going to do is they're going to do a diverting colostomy. They can do a couple of things. They could do a loop. I very rarely see them doing a loop. What I see them doing most of the time is a Hartmann's pouch. So they divide the bowel. They usually just leave that denervated bowel. They just leave it sitting there. It has blood flow. Nothing's going to happen to it. So they divide the bowel. They bring the end of the normal bowel, the bowel with nerve cells, out onto the abdominal wall. Now remember, this is a section of bowel that's very distended, and so they're going to start out with a very large stoma. Very important to tell the parents that. They're going to start out with a very large stoma. It's going to shrink down over time. That's one of our goals, to get that bowel down to normal size so we can look at connecting that colon to the anal canal. So once that bowel shrinks down to normal size, then they can do what they call a pull-through procedure. And there's a number of different specific surgical techniques. I'm not going to get into that. But the bottom line is, you're going to take out this section of bowel that does not work. You're going to pull the proximal functional bowel down and connect it to the anal canal just above the internal anal sphincter. Now, that's going to restore pre-normal stool elimination. However, you will still have that internal sphincter that does not open in response to distension. But think about the alternative. If you go past the internal sphincter and connect the colon to the anal canal, you'll lose the functions of the internal sphincter, and the internal sphincter is what provides us with continence at rest. We can teach that child to use abdominal muscle contraction to push stool through that contracted internal sphincter, but there's no way to compensate for absence of the internal sphincter. So to recap treatment, initially, diverting colostomy to provide gradual decompression and shrinkage of the colon. Then they're going to connect the functional colon to the anal canal just above the internal anal sphincter. And then they'll close the colostomy. And usually they do the pull-through and the colostomy closure in one procedure. So the baby usually ends up having two procedures, the initial diverting colostomy, and then the pull-through and closure of the colostomy. Long-term, most of these children do have normal bowel function, but it is very important during toilet training, that toilet training period, and throughout this child's early life, that the child gets enough fiber and fluids so that they have bulky stools that are relatively easy to eliminate, and that the parents, and if necessary, the medical team works with that child to teach that child normal bowel habits, how to use his or her abdominal muscles, and deep breathing to push the stool through that anal canal. So let's see if there's anything else I wanted to go over related to short segment. I think that's it. What about long segment disease? Well, here you see, in this case, there's ganglion cells in the ascending colon, but none in the transverse descending sigmoid or rectum. With either long segment or total colon aganglionosis, those babies will be diagnosed quickly. Almost always they're diagnosed early because they are obstructed, so they cannot tolerate feeds. So the advantage of that is that with early diagnosis, you don't get this massive distension of the colon. So usually they can go in, they can do the biopsies to see exactly where the ganglion cells end. They can remove the non-functional colon, and they can connect the proximal colon to the anal canal. Again, uncommon, 10 to 20% have long segment or total colonic aganglionosis. I want you to focus on short segment. Those are the patients you're going to be consulted on, and that's a much more common condition. Now, looking at long-term outcomes and complications, there is a complication known as enterocolitis. It's much more common in infants than in children, very unlikely to occur after age 2. Break it down: entero, small bowel, colon, itis, inflammation. So you have a rapidly progressing infectious process involving the small bowel and the colon. It can be fatal. So let me back up. It can be fatal if not treated early and aggressively with antibiotic therapy. So what we tell parents of a child that's been diagnosed with Hirschsprung's, both before and after surgery, is if your child develops diarrhea, don't wait it out. It could be the first sign of enterocolitis. Call or come in so that we can evaluate the baby, make sure that this is just a viral gastroenteritis, nothing to be worried about, versus enterocolitis, which mandates treatment with antibiotics. Again, not common, but important to know about because we have to counsel parents appropriately. There's a very small percentage of kids who develop recurrent aganglionosis, very uncommon. I'm not going to ask you that. Probably the most common complication after surgery for Hirschsprung's disease is problems with bowel elimination. And that child could have either a chronic constipation, or they could have chronic constipation associated with leakage of liquid stool around the bolus of impacted stool. Here's the reason. Go back to that internal sphincter. We connected the colon to the anal canal just above the internal sphincter. Internal sphincter does not open, so it's critical for that child to learn effective bowel habits to push the stool through the anal canal. If that child does not learn how to overcome the resistance of the internal sphincter, they can develop significant constipation, and then liquid stool leaks around the bolus of impacted stool, and that child can have incontinence. Probably a more common problem is that you can get stricture formation, because remember what's happened. I'm going to go back one. Actually 2. Because remember what they've done is they've connected proximal colon to the anal canal. So you have an anastomosis between the bowel and the anal canal. Any anastomosis has the potential to form hypertrophic scar tissue. And so you can get a very tight ring of scar tissue right at the junction between the anal canal and the colon, right at the coloanal anastomosis. That usually occurs early post-op. One of the things that you have to be aware of in talking to the parents is that early post-op, they will be monitoring that child for any stricture development. And if any strictures do begin to form, they will teach the parents how to do gentle dilatation on a daily basis to keep that stricture open, keep that pathway open, and to overcome that stricture so that that child can have normal bowel elimination. So this is the complication that's most common, is problems with stool elimination, severe constipation caused by either that hypertrophic sphincter in a child who has not learned how to overcome that sphincter resistance, or stenosis at the coloanal anastomosis, or some combination. Think about the combination of a stricture plus that abnormally tight sphincter. So monitoring the anastomosis, managing any stricture formation early, making sure that child gets enough fiber and fluid to keep their stools bulky so that it's easy to push the stool through. Working with the child during potty training, making sure that their feet are on the floor, that they sit with their back straight. They can lean forward, but they should never hunch over so that they get maximum abdominal pressure. Teaching them how to use deep breathing and pushing to push stool through the anal canal. All of those strategies can overcome any issues with stool elimination. So if you were talking to a parent of a child with Hirschsprung's, remember we're focusing on short segment disease. They're going to be asking you, what should I expect? After the biopsy, then the child's going to have a temporary colostomy. We'll teach them how to manage the colostomy. They'll usually have the colostomy for somewhere between 2 and 3 months, long enough for the colon to shrink down so that the anastomosis can be done. Then the colon will be connected to the anal canal. Early post-op, close monitoring to be sure that the anastomosis is healing normally, that there's no stricture formation, or if there is stricture formation, to do gentle dilatations to keep that pathway open. As the child grows, the critical importance of making sure they're getting enough fiber and fluid, and then critical strategies during toilet training. Now, what are you likely to be asked about Hirschsprung's? Well, I want you to know what it is. A congenital absence of nerve cells affecting variable lengths of the bowel. I want you to know that diagnosis is by rectal biopsy. I want you to know that management involves a temporary colostomy to decompress the bowel and allow the colon to shrink down to normal size, followed by what they call a pull-through procedure, anastomosis of the colon to the anal canal, and closure of the colostomy. I want you to know that long-term complications, the two I really want you to be aware of are enterocolitis and the potential for problems with stool elimination. Okay, now we're going to talk about imperforate anus. Imperforate anus is actually an umbrella term that includes any abnormality in the anorectal area. So if there's any problem with development of the distal rectum, the anal canal, the sphincters, and the anal opening, is put in that bucket and known as imperforate anus. Now, the first indication is there's no visible anal opening, or you can't do a rectal tent because the little dimple, that little, what looks like an opening, doesn't go anywhere. That's why it's called imperforate anus. It can occur alone, it can occur in conjunction with other congenital anomalies. So you see in your module about the Bacterial syndrome. And I'm not going to ask you that. I just want you to be aware that there are many structures developing at the same time as the distal GI tract. So sometimes the baby's born not only with imperforate anus, but also with renal issues, as you see, vertebral issues, tracheoesophageal issues, cardiovascular issues. We always want to be aware of what else is going on, how many things are these parents dealing with. Now, in looking at what happens, I want to go through low lesions, intermediate lesions, high lesions. I want to explain this slide first, and then I'm going to go through low lesions, intermediate lesions, high lesions, talk about what it means and what the implications are for prognosis. On the top, you see normal anatomy, and then imperforate anus in the female, how it presents, and then in the male. So of course, this is normal, where the distal GI tract has developed totally normally. You've got the rectum, anal canal, anal opening, all lined up appropriately. Okay, you can have formation of the distal rectum, but you can have failure to form the anal canal, or the anal canal can be closed over by skin. Sometimes what happens is that the distal rectum and the anal canal form, but the anal canal does not line up with the anal opening, with the anus itself. So you see that. It's in the wrong place, or it's very stenotic. And then these are your more serious issues. Here you can see that the distal rectum and anal canal did not form. Instead, the bowel ends in a blind pouch or ends in a fistulous tract. And girls, the fistula goes to the vagina, and boys, it typically goes to the urethra. So boys are passing stool urethral, girls are passing stool vaginally. There is another anomaly known as cloacal exstrophy. We'll mention that briefly in another class. I really don't want you to worry about that. Okay, so let's talk about low lesions, intermediate lesions, high lesions. And before I say anything else, here's your take-home message. Low lesions and intermediate lesions have a much better prognosis in terms of fecal continence, because almost all of the critical structures, or all of the critical structures, were developed. In contrast, high lesions do carry the risk of fecal incontinence because they have incomplete formation of the sphincter. So we're going to talk about each of these. Now, with low-level lesions, that means that the distal rectum formed, the anal canal formed, the sphincters formed. So the sphincters are intact. And just as a review, internal sphincter, smooth muscle, not under your voluntary control, but provides continence at rest because it stays tight. So it keeps small amounts of stool or gas from leaking out. A normally functioning internal sphincter, when the rectum distends with stool or gas, the internal sphincter opens to allow stool and gas to pass into the anal canal. The external sphincter is your voluntary sphincter. So when you feel stool or gas starting to pass into the anal canal and you tighten up, like, no, that's because you have voluntary control of the external sphincter. So your internal sphincter provides continence at rest, and I always say the external sphincter provides continence under stress or under duress. When the rectum is full or has stool and gas and you're trying to retain that stool or gas until you're in an appropriate place for elimination, that's when you use your external sphincter. So with low-level lesions, both the internal sphincter and the external sphincter formed normally. That's critical. That tells you right there that long-term, this child is going to be continent. So there's one of two problems. Either the anal opening is covered over with skin, Or sometimes the anal canal doesn't line up with the anal opening. So the anal canal comes over here, here's the anal opening. Well, you can see those are quick fixes. If I've got a covering flap of skin, they can just cut it away. And if the anal canal is not lined up correctly, again, they can align the anal canal with a simple plastics procedure, align the anal canal and the anal opening. If the anal canal is stenotic, they can dilate it. The critical thing to realize with low-level lesions is that all the critical structures are there and normal, internal sphincter, external sphincter. So we can take away the skin, we can correct alignment issues, and we can dilate if there's stenosis of the anal canal. All very fixable. So low-level lesions, you're probably not even going to get involved with because they're not going to need an ostomy. They're going to be repaired early, and we expect totally normal continence. What about intermediate lesions? Well, intermediate lesions, again, the distal end of the bowel formed, the rectum formed, and it passes at least part way through this pelvic sling. So your pelvic floor has this very thick muscle known as the levator ani. It's the muscle that surrounds the anal opening, and that gives us great control. So when you have an intermediate level lesion, and I'll go back and show you this, okay. With your intermediate level lesion, it doesn't really show it well. It shows low and high. But if you had an intermediate level lesion, what would happen is that the rectum would form, and the anal canal would form, and would get almost all the way through this pelvic sling, but not quite all the way. So again, when the baby's born, do you see an anal opening? No, there's no anal opening. But are all the critical muscles there? Yes, so the only thing that didn't form was the very distal anal canal. And a lot of times these kids do have a fistula opening that'll track to the vagina or to the urethra. So they just have to take that fistula little tract, that little anal canal that's connecting inappropriately. So it would actually be much lower down. It shows that high, but it would actually be low down, more like you see here. So what have they got to do? Disconnect this little tract from the urethra and bring it to the anus. But remember, internal sphincter intact, external sphincter intact. What does that tell you about long-term outcomes? Very good. So I want you not to focus on this because it really isn't the best depiction. I want you to think more of this because distal rectum did form. You've got the anal canal, but it's connected not to the perineum, to the urethra, to the vagina, so you just got to redirect. But again, you're going to see in just a minute, excellent prognosis, okay? I want you to know about high lesions, also known as rectal atresia. These are the babies you're going to be consulted on. These are the babies where you look, you're going to have something like this or something like this. So did the rectum form? Did the distal rectum form? Did the anal canal form? Did the internal sphincter form? And the answer is no. The bowel ends in a blind pouch that's well above that pelvic muscle sling. Now the pelvic muscle sling is still there, and that's a good thing. The problem is the anal canal and the internal sphincter did not form. So they do not have an internal sphincter. What did your internal sphincter do? It provides you continence at rest. So these kids don't have that. They don't have that internal sphincter to provide continence at rest. The external sphincter, remember that the external sphincter is tied into that pelvic muscle sling, and that pelvic muscle sling is usually intact. So what they're going to end up doing long term is they're going to actually reconstruct the distal end of the bowel. So they're going to bring the bowel down. They're going to create a pathway from the blind pouch to where the anus should be. And they can use E-stem to determine where the highest concentration of muscle fibers are. And that tells them this is where the anal opening is supposed to be. This is where we have that very high concentration of muscle fibers. So they're going to line up the anal canal that they create, the newly created anal canal. They're going to line that up with where the anus should have been. So they will have some voluntary control, but they don't have continence at rest, and that's very significant. We're going to get back to that. But what are they going to do initially? Because this is a very advanced repair procedure. It's not done in very many places. Dr. Pena is the leading surgeon for this procedure. So this baby's going to require workup. The baby's going to require transfer to a major treatment center. And then they'll do what they call the pull-through. But in the meantime, we need to feed the baby, so we have to establish a pathway for stool elimination. So babies with high lesions in perforate anus, that's classified as a high lesion, also known as rectal atresia, where the rectum formed or part of the rectum formed, but the distal rectum, the anal canal, did not form. The rectum ends in a blind pouch. Those babies are going to require temporary colostomy. So they'll be diagnosed. They're going to have a temporary end colostomy. That allows them to feed the baby, allows the baby to grow normally, while workup is being done, while plans are being made for reconstruction. When they get ready to do reconstruction, they're going to disconnect the stoma from the abdominal wall. They're going to mobilize the distal bowel. They're going to pull the distal bowel down. They're going to create a channel, a little pathway between the distal bowel and the perineum that serves as the anal canal. They're going to connect it to the point on the perineum where the anus should have been. But as you can see, the prognosis for continence is not as good because you don't have the internal sphincter and you don't have a normally innervated anal canal. So you can see that for these kids it would be very critical early on to get them on adequate fiber and fluid so that they have consistently bulky stool. We want them to form extremely regular stool elimination patterns because that's their best bet for long-term continence. We want to teach them to use their external sphincter to control stool elimination. But we know that they are higher risk for incontinence because they do not have all of the control structures that children with a low or intermediate level lesion have. Now, if you look on your handout, it tells you that most of these kids achieve continence by the time they reach adolescence. But that's a long time. And you don't want these kids to be having accidents in school because that has such a negative impact on psychosocial development. So working with the parents, working with the kids early on during toilet training preschool years to try to establish very, very regular bowel habits. But I did want to just mention an option for kids who do have a long-term problem, and it's called the ACE procedure or antegrade continence enema procedure. First done for children with neurogenic bowel, and now also done for children who have any problems with bowel control, such as kids post and perforate anus repair. So basically what they do, a couple of different approaches. In the pediatric population, they'll frequently put in a little tube into the ascending colon, and it closes off at skin level, so you can open it or close it. When you open it, you can insert a catheter. You can have the child sit on the toilet and you can literally flush through. So you're going from top to bottom. You're starting at the ascending colon, you're literally flushing stool through. That's why it's called antegrade, so you're going forward, whereas with an enema, you're going backwards, and that's retrograde. So it's literally a washout, a colonic washout. And these kids typically do this every other day, sit on the toilet, feed the catheter in, and just flush from top to bottom. And that clears out the colon and keeps them continent in between each washout or irrigation. Now the other way they can do this, instead of putting a tube in the ascending colon, they can also remove the appendix and reverse the appendix, feed the appendix into the ascending colon, bring it out of the umbilicus. And because it's so tiny and they've reversed it, so peristalsis is going toward the colon, then there's very, very low risk of leakage. But in kids, many times you'll see them putting in the tube, and then just opening the tube and feeding the catheter in. So I want you to know that if you're talking to parents whose child has a high level lesion, rectal atresia, you're talking to them because they're going to do a colostomy or they have done a colostomy. They're talking about the pull-through procedure and long-term prognosis. You want to be able to say, most kids have good outcomes. These are the things that we can help you with to improve outcomes. However, should your child have problems with bowel control, I want you to know that there are options out there. Bottom line, we're going to work with you to give your child good quality of life. Meconium ileus, I will not test you on. Meconium ileus basically refers to a mechanical obstruction. You have a section of bowel, typically in the ileum, that becomes blocked with dried out meconium. It's much more likely to occur in kids with cystic fibrosis or Hirschsprung's disease, especially the long segment Hirschsprung's disease where stool's not moving through. Cystic fibrosis where you have abnormally thick, dry secretions in the bowel. Most of the time they can pass an NG tube and give gastric graphene or even mucomist by the NG tube, and that pulls a lot of water into the gut and liquefies the meconium so it can pass through. Occasionally they have to go in and resect the section of bowel that's obstructed by the meconium and do an end-to-end anastomosis. Very unlikely to do anostomy. I haven't seen anostomy for meconium ileus in many years. I will not ask you that. But I will ask you about necrotizing enterocolitis. Almost all of you, if you work in agencies where you have a NICU, you're going to see a number of infants with necrotizing enterocolitis. It's actually been called a complication of modern neonatal care because a lot of times it affects infants who are very small and very vulnerable, and these babies would have died in the past. These babies survive now because of our neonatal care. They're also higher risk for certain complications. So break the term down. Necrotizing enterocolitis, NEC. Necrotizing, clearly you have got progressive ischemia and necrosis of the bowel. Entero, small bowel, colo, large bowel. So obviously this necrotizing process involves both the small bowel and the large bowel. It always involves the terminal ileum. It can involve variable lengths of the colon. And sometimes you'll have skip areas, so you'll have more than one area of the bowel involved. Very serious complication associated with prematurity. Almost all babies with NEC are premature. It can occur in a term baby, but it's very, very, very uncommon. And it can cause death. Now, what causes it? You start out, you have a very vulnerable infant. That means that they are also very vulnerable to bowel wall ischemia. Some of these babies require resuscitation at birth, so they could have sustained some ischemic damage to the bowel wall during the resuscitation period. Sometimes they've been very unstable and they've had hypertensive episodes that could have caused ischemic changes. Some of them have associated cardiovascular anomalies that could cause ischemia. So the baseline condition is vulnerable mucosa of the GI tract, okay? Some degree of ischemia, rendering the mucosa very vulnerable to bacterial invasion. Once you have a vulnerable bowel wall, then bacteria can easily penetrate and can set up an acute infectious process. Now, interestingly, breast milk is protective, or seems to be protective. There's much lower incidence among infants who are fed breast milk. So you're probably aware that moms of premature babies are encouraged to pump their breast milks and to save it so that once the baby's ready to begin feeds, they can feed that baby breast milk, either by gavage feeding initially, and then later on by bottle, and eventually by breast. In contrast, commercial formula is thought to possibly further damage the mucosal layer of the gut and further contribute to the mucosal injury that then permits bacterial invasion. So premature babies need breast milk, not commercial formula. Okay, if the baby develops NEC, it usually occurs at the time we start feeding them. And what you see is rapid distension. You see a baby that just becomes very unstable. They have temperature instability, respiratory instability. They're very lethargic. But of course, the giveaway is this very rapid abdominal distension that you see right here. Now, when they do an x-ray, and they'll always do an x-ray, and you'll see this classic sign, they call it pneumatosis intestinalis, and it's like a halo of gas around the gut. And what it represents is gas produced by the anaerobes. So it's a very serious finding, the pneumatosis intestinalis, gas forming in the bowel wall, creating a halo around the lumen, points to impending perforation. And usually if they see that, they're going to go in and take the baby to surgery before they perforate. So they watch babies very, very carefully. They watch them all the time. They watch them particularly carefully when they initiate feeds. If they note any increasing distension, any increasing instability, they're going to stop the feeds. They're going to do antibiotics. I talked to one neonatal intensive care nurse, and she said they routinely covered babies during initial feeds with antibiotics to see if they could prevent NEC. They do the workup, the x-ray, they see distension of the bowel, they see developing gas in the bowel wall. They're going to take the baby to surgery. When they take them to surgery, they're going to find a necrotic length of the bowel. They're going to take that out. So they're going to take out all of the clearly necrotic bowel. And they're going to bring both ends of the bowel to the abdominal wall. So what did we say? We said the terminal ileum was always involved. So you've always taken out part of the ileum, part of the colon. That means you're going to have a functional ileostomy. That will be your proximal stoma, your functional ileostomy. And you'll have a colon mucus fistula. Now, some surgeons put them side by side and they're pouched in one pouching system, and other surgeons separate them so you can pouch the proximal and dress the distal. But that will probably be a test question. What would you expect to be done for an infant with necrotizing enterocolitis? Resection of the necrotic bowel, a functional proximal ileostomy, a distal colon mucus fistula. Obviously, temporary. Was the baby stable, gaining weight, doing well? They're going to reconnect the bowel. Now, you have to be aware that in a very small subset of these patients, they have very extensive necrosis, and when they get in there, they're not able to do anything therapeutic. They end up just closing them and keeping them comfortable with pain meds. But the vast majority have a defined section of bowel involved. They can take out the necrotic section, bring out the proximal end, bring out the distal end. We also have to be aware that if they have to remove a large portion of the bowel, then that baby is at risk for short bowel syndrome. But most babies is primarily the distal ileum, acini-colon, maybe some other little patchy areas that are involved as well. Most babies have adequate bowel length. Most of them, once we do the reconnection, do well with no long-term sequelae. So it's a very acute complication. It can result in death. Very frequently results in a temporary stoma, but most babies do well long-term. So what will I ask you about? I want you to know what's involved, what the pathology is for necrotizing enterocolitis, damage to the mucosal layer, either because of ischemia, possibly exposure to commercial formula, invasion by the gut bacteria, and rapidly developing infection of the bowel wall. How do we manage necrotizing enterocolitis? Surgical resection of the necrotic section, and then bring out an ileostomy as your proximal stoma, the functional stoma, and bring out the colon as the distal mucus fistula. Okay, so definitely temporary. Definitely need to know about necrotizing enterocolitis. Definitely need to know about Hirschsprung's disease. Definitely need to know about imperforatus. Those are the big three, and those three will definitely be on the test. This, on the other hand, will not. But I'm going to go over it just in case, because every time I take it out of the syllabus, somebody calls me with questions, so then I know, oh, they're doing that procedure again. Biliary atresia. Well, now you know what atresia means. It means loss of continuity. And biliary atresia is the progressive obliteration of the bile ducts. It's the extrahepatic bile ducts that take bile from the liver to the small intestine. Now, that creates two problems. If you lose the bile ducts, so you get progressive obliteration of these ducts that normally take bile from the liver to the small bowel, of course it's going to interfere with fat digestion and absorption, but that's not the critical thing. The critical thing is that the liver's making bile, but it has no way to get bile from the liver to the small bowel, so the liver is becoming engorged with bile that gradually destroys the liver. So it's really the impact on the liver that is the big concern in protecting the liver. If the baby has advanced biliary atresia or does not respond to therapy, then they're going to end up with a liver transplant. But in between, there's the opportunity to do something called a Kasai procedure. So think about what the problem is. It's basically a delivery problem. Bile production is normal. The gut is normal. We've got to get bile from here to here. So a very simple way to do that is to remove a section of jejunum and connect the section of jejunum to the liver where the hepatic ducts came off, and then bring it down and connect it to the bowel, okay? So that now you have another pathway for delivery of bile from the liver to the small intestine. And if we get that child diagnosed early, then they can do that before any significant liver damage occurs. A lot of these kids do well. Now there's a modified Kasai where they take a section of jejunum, they connect it to the liver, then they bring it out to the abdominal wall and back to the small intestine. And you're probably thinking, why would they do that? So they actually bring it out onto the abdominal wall. And I'm a terrible, terrible, terrible artist, as you will see. So here's your liver. So they take a section of jejunum and they connect the section of jejunum, then they bring it out to the abdominal wall, and then they bring it back. So let's say here's your stomach, okay, and here's the small bowel. Here, they've made a loop stoma out on the abdominal wall. So we're going to end up pouching this loop stoma. So you still got the pathway to get bile from the liver to the small bowel, but you've brought it out onto the abdominal wall. They do that so that they can monitor bile production. It doesn't really impact on clinical outcomes, but it does make management much more difficult. Because when they do it this way, then they want you to pouch the stoma, they want you to collect the bile in the pouch, then they want you to empty the bile into a little cup. They want you to then feed a little red rubber catheter into the distal end of the stoma and refeed the bile. And we're thinking, why didn't you just do a straight connection? Why didn't you just connect it from the liver to the small bowel? And then nobody has to do all of this pouching and collecting and refeeding. Hopefully you will not see that, but I wanted to just walk you through just in case. Hopefully, just in case. Okay, so now let's just go very quickly through pediatric pouching guidelines. Basically, we want to keep it very simple and straightforward. First thing you want to do is determine, does this infant require pouching? Okay, now if it's an ileostomy, absolutely. We have to find a way to keep a pouch on because ileostomy output, as you know, is highly enzymatic and much higher volume, and it's going to digest the skin. So ileostomy, yes, we always pouch. Now with a colostomy, the parents actually have a choice. They can pouch, or they can use like a little bit of Vaseline gauze or Xeroform gauze to protect the stoma, and they can just diaper the baby. Put zinc oxide around the stoma if they want to. Most parents pouch, but there is the option not to pouch. So just be aware of that. If you have a left-sided colostomy, pouching is optional. And of course, with the urinary diversion, as we'll cover in a later class, we do not routinely pouch. Now, we have a couple of goals. Number one, we want to prevent skin trauma. These are very vulnerable babies. They have that newborn skin. A lot of them are prematures, and so they have even more vulnerable skin. Very high risk for skin tears and tape trauma, so we have to be super, super careful to prevent any trauma. And as we've already said, we also have to be very careful in product selection. We have to be aware of the differences in neonatal skin and adult skin, and think twice or 3 times before we use something on that infant skin. So what can we do to prevent skin trauma? One thing that's helpful is the fact that pediatric pouching systems have less aggressive adhesive. So they're gentler to the skin. When you go to peel them off, you'll notice that they peel off more readily than adult pouching systems. That is done on purpose by the manufacturers to help protect infant skin. So notice that. We now have silicone-based adhesive removers. In the past, some of us have used petroleum-based adhesive removers. Then you have to try to get all the petroleum off the skin. Silicone-based adhesive removers are very skin-friendly and don't leave any kind of oily residue. You'll find 2 schools of thought in regards to use of solvents, adhesive removers. Some pediatric WOC nurses routinely use the adhesive remover, especially the silicone-based, and others prefer just to use warm water to take a cloth, wet it in warm water, and to kind of work the pouch off with that. We don't have any evidence to say that one approach is better than the other. The goals are the same, prevent trauma. So however you go about it, you're always trying to protect the skin. And of course, just emphasizing to everyone how important it is to be very gentle in taking care of this baby's skin. Now, that's one advantage in dealing with pediatrics as opposed to geriatrics. People just look at babies and think gentle. Unfortunately, they don't look at geriatric patients and think gentle. We would be in a much better position in protecting their skin if they did. But people are usually very gentle with infant skin. Now, just a couple of things in terms of emptying the pouch. You know, it's very different when you have a baby. Emptying the pouch is different than if you have a school-age child. So with infants, we typically, a lot of times in the hospital, we will angle the pouch to the side to make it easier to empty the pouch. Once they go home, I usually angle it down because a lot of times I'll just let the mom or dad empty it into the diaper, and it's easier to conceal in the diaper once we angle it down. So when they're going home, typically down, but while they're in the hospital, frequently to the side. In the hospital, they're doing very strict INO, so they will frequently open up the end of the pouch, use a catheter tip syringe, pull the stool out, empty it into a cup, and measure it. But at home, we just tell them when you're changing the diaper, before you throw away that wet diaper, open up the end of the pouch, let it just drain into the diaper, wipe off the end, and close it back up. Toddlers and preschools, of course, you want them to empty into the toilet, obviously. And then as they move into the preschool years, you want to start transferring responsibility for emptying the pouch to the child. We'll come back to this during growth and development. And then school age, of course, they're either going to sit or stand. Most kids sit, but some might stand. They're at a pretty good angle to stand and empty, whereas adults are pretty much too high. They can put toilet paper in the toilet first so that they don't get splashed back. And then have wet wipes to clean the end of the pouch. Now, what do we expect in terms of pouching duration? With adults, we talk about 3 to 5 days. We don't say that with infants. We tell parents, you know, sometimes you'll change this pouch 2 or 3 times in one day. Other times it might stay on for 2 days. So 12 to 24 hours is common. Some kids will get up to 2 to 3 days, but 24 to 48 hours is probably the most common. We've talked about you might want to put the pouch on sideways while they're in the hospital. If they're drawing up their legs and that's interfering, you can use the papoose while you're pouching them. Give them their pacifier, of course. And one thing that is extremely helpful is to put the paste in like a 3 cc syringe. So get your paste, withdraw the plunger, put your paste in, put the plunger back, and then you can literally pipette the paste where you want it to go. Now remember, if this is a premature or a newborn within the first 2 to 4 weeks of life, we try very hard to avoid putting paste directly on the skin. Instead, we would put paste on the back of the pouch. We would cut the pouch out, put the paste on the back, lay it to the side, allow all the alcohol to evaporate before we put the pouch on. If we have an older infant who's well past that first 2 to 4 weeks, yes, you can put the paste directly on the skin, and the syringe is very helpful with that. And then we'll talk about this again when we get to growth and development, but you know how babies explore, they like to snatch pouches off. So as soon as they get to that stage, we put them in onesies so they can't get to the pouch. For your toddlers, 2 to 3 year olds, we've talked about, usually we can keep the pouch on for 2 to 3 days. It is variable. Many times we have to change the pouching system if the child still has an ostomy at this point, so maybe they've been in a 1-piece, we go to a 2-piece. Maybe they've been in an all flexible and we go to one that has a flange and gives them a little bit more stability. A lot of the same things, 1-piece outfits and undershirts, and they don't pick at it. But here you're trying to distract them, entertain them while you're changing their pouch. And then the preschoolers, this is where we frequently will pouch the doll or pouch the stuffed animal. Hollister has some little soft, they're like dolls, but they're just soft stuffed dolls with little stomas. And so you can get those from Hollister and let the preschooler pouch the little doll before you pouch them. It's also helpful for a lot of them if they name their stoma, then they can talk about the stoma. So involving the preschooler in his/her own care, and we will come back to this. This is just some resources. WOCN Society does have pediatrics ostomy care best practice guidelines. All of your major vendors, Coloplast, Convatec, Hollister, and then Incotec has the premium pouches. And then just support groups that are out there. Again, this will be incorporated in some other classes, but just wanted to mention it specifically to peds. There is a teen network for teenagers with ulcerative colitis or Crohn's. You see in Crohn's.org. There's actually a pull-through network for kids who undergo pull-through procedures for Hirschsprung's or imperforate anus, or for inflammatory bowel disease. We'll come back to that in later classes. UOAA has a teen network, and UOAA is your primary ostomy support group. They have subgroups for different populations, so they do have a subgroup for teens. And one thing that I did want to mention is that UOAA sponsors a youth rally every year for kids and teens with ostomies or fecal urinary incontinence. It's a wonderful opportunity for kids. It's a wonderful opportunity for ostomy nurses. Ostomy nurses can apply to be camp counselors, and kids can apply. So if you want to find out more about it, you can just go online. You can just Google youth rally for kids with ostomies, and you can get the information about the youth rally that's coming up next. Okay, that's it. We will, of course, go over pouching details and options and look at pediatric as well as adult pouches when you're here for Bridge Week. Back to what do you need to study? Focus on Hirschsprung's, imperforate anus, necrotizing enterocolitis. Okay? Thank you very much.